So the issue of dystonia and trauma is not a new one. This has been around, the concept, since the 1800s, actually, where there were some initial descriptions of cervical dystonia, for example, after head trauma. And there's been an ongoing consideration about this, particularly in the area of musicians' dystonia, or people are having repetitive movements and then developing dystonia in that part of the body. For example, a pianist that I think we all heard of in the past, or even people who are singers, or people who are doing, for example, some of my patients who are doing a lot of work at a keyboard, a lot of writing, have developed dystonia in that part of their body, suggesting that these repetitive and maybe small traumatic trauma-associated movements are a contributing factor to developing dystonia into that body part. Let's see. Some disclaimers. This was a picture I took while I was still living in California. This guy's got a disclaimer on his bumper, very proudly displaying his political thoughts. But I've done clinical trials with Allergan, the manufacturer of Botox, and I've served on their speakers bureau as well. And I'm just going to give you a heads up at the beginning of my talk that I may be leading you astray, because these are my thoughts and not necessarily at this time widely accepted in the medical community, for example. These are just, I thought I would come up with some provocative, I hope, ideas about the topic of dystonia and trauma. So I may be leading you off a cliff. So what do we know about dystonia? Well, you know all this. It's classified as a so-called hyperkinetic movement disorder, where people are having excess movements rather than a paucity or reduction of movements, such as a hypokinetic movement disorder. An example would be Parkinson's disease. It causes abnormal postures and repetitive or sustained movements. And with that come the end result is our overcontraction of muscles, and also co-contraction of so-called agonist and antagonist muscles. Normally, when I want to extend my arm, the triceps muscle is engaged and the biceps relaxes. But in dystonia, both of those muscles are co-contracting and fighting against one another. And how about what's actually happening in people with dystonia in the nervous system? There's actually been a lot of description, mostly by imaging studies and physiological studies using something called transcranial magnetic stimulation, measuring magnetic or electrical potentials on the surface of the skull in people with dystonia. And there's been a lot described, but I think this is just descriptive information. It's not really telling us the cause of dystonia. It's just telling us what's going on, mostly in the brain. And again, the concept of dystonia has been mostly brain-based, that this is a brain-related disorder. And I think with a little bit of thought, we've understood that it's not just a brain disorder. It's actually the brain interacting with the environment that's causing the problem of dystonia, the environment being our limbs, for example, where we are in space. Sensory information that comes in from the environment through our limbs, our head, our neck, and then sending signals out. So it's really a problem of, as the first bullet point indicates, altered sensory motor integration. And they say loss of inhibition at several levels in the central nervous system, meaning the brain and the spinal cord, and changes in something called synaptic plasticity. Martha, years ago, helped me and my colleagues and I with a study that we did in cervical dystonia, looking at a gene type that was associated with an altered plasticity in the central nervous system. And it was found, at least in our study, not in everybody's, that people with cervical dystonia had a gene associated with increased plasticity, meaning it's harder to regulate the response to the environment. What we know about why this happens, well, we're sort of in the infancy of why this happens. There's a lot of interesting stuff out there, but it really is not clear why any of these things occur. the descriptive information we have about the brain changes, for example, is not telling us why this occurs in the first place. There have been some clues along the way. We know that there are some genes associated with dystonia. Most people don't carry these specific genes, but there are uncommon families where there is a genetic abnormality that leads to dystonia. This is more often identified in childhood onset dystonia. There have been some clues about genes for decades, actually, as long as I've been working as a neurologist and before. There were studies earlier, mostly out of England, that were examining family members of people who did have cervical dystonia. And although there was no discrete family history of cervical dystonia, when the family members were examined, there were a lot of subtleties that were detected, more so in those family members than in just the general population. Subtleties like tremor, for example, or other fairly modest or minor examples of dystonia. We're well aware that certain medications, and mostly those that interfere with the transmission of dopamine in the brain, can trigger dystonia. One sees it occasionally, and sometimes in a dramatic way, that people have had rather diffuse dystonia involving the spine, more often in people, and more often in men, using antipsychotic medications. But can sometimes cause some awful dystonia, generalized dystonia. It's also known that on occasion, structural changes, for example, from a stroke or a tumor, can result in dystonia. Although when we scan the brains of people who have dystonia, most often we see a normal brain. We don't see any structural changes that are causing or contributing to the dystonia. And as I mentioned, it's been known for, gosh, a couple of 100 years or more that trauma, both to the brain or to the spinal cord or to the periphery, meaning outside of the brain and the spinal cord, can be a contributing or provocative factor for dystonia. This is a picture of an MRI scan, just showing an example of, I don't know if you can see my arrow or not, but there's that little white area toward the left of this is like sort of what's called a coronal view of the brain, meaning it's taking a slice, sort of looking from front to back. And over here on the right-hand side, you can see a whitish area, which is a stroke in an area of the brain called the globus pallidus, resulting in dystonia on the opposite side of the body, on the left-hand side in this case. And that's been described for years and years. And that was how people started to think of dystonia really as a brain-related problem, because on occasion, structural changes, as in this example, the globus pallidus, and more often in a brain structure called the putamen, would lead sometimes to dystonia. Although I have to say, most people who have a stroke in their putamen or in their globus pallidus do not develop dystonia. This is some images from a paper from the Mayo Clinic in Rochester, Minnesota. Sherwood Goldman and Eric Alskog published this paper years and years ago about people who had, in a sense, peripheral trauma. This was not necessarily brain trauma, but a head or neck injury resulting in dystonia. This is described as cervical dystonia, but I'm sure you can see that it's involving the trunk. You see the rather dramatic tilt toward the subject's left, and not terribly prominent, at least in this picture, cervical dystonia, but a lot of truncal tilt. And here you see the shoulder involvement. This is from the same paper of another person who had head or neck trauma that resulted in dystonia. The concept of trauma contributing, or peripheral trauma contributing to dystonia, I think was sort of argued back and forth for a number of years. I think people have settled on the idea that a peripheral trauma, meaning not an injury to the brain or the spinal cord itself, but the injury to the head, the neck, or limb, can result in dystonia. This is from a different paper. This is a case report by a woman, Dr. Oaklander in Massachusetts, also some years ago. And this woman, young woman, had a vein stripping procedure on her right leg. And I don't know if you can see it in the upper panel on the left, but there's a slight inversion of that right ankle. This is a month after she had the procedure done. And you can probably also see in the panel that's marked B with the letter B, the inversion of that ankle. This again is the same time. It's a month after the procedure was done. And you can probably appreciate there's some edema, some swelling in that foot and also in the ankle. The picture to the right is, I believe, as I recall, 3 years later, as this dystonia continued to develop. And what she has is dystonia associated with something called complex regional pain syndrome. And what is that? Well, that is what was previously called causalgia. It was first described in the Civil War in this country back in the 1800s. It was later called reflex sympathetic dystrophy, but people have settled on the name of complex regional pain syndrome, or CRPS. Not that people keep renaming things. It makes you think we're getting smarter, but we're not necessarily getting smarter with the change of the names. Maybe people feel it's just more descriptive of what this thing is, which is quite, by the way, nasty. The clinical features are that woman had a rather mild procedure, the vein stripping procedure in her right leg. But people who have this, sometimes after a fracture, a wrist fracture, for example, an ankle fracture, or even a minor surgery like the vein stripping, people have continuing and disproportionate pain in the area affected. People develop a very unusual sensitivity in that area. So that woman's foot that you just saw in the previous slide with the turning in is typically those limbs are not only swollen, but they're warm to the touch. They're painful to the touch. There can be changes in the hair and the nails and the skin. And there are motor changes associated with this nasty entity, including diminished range of motion, weakness, tremor, and dystonia. These the last two things probably ring a bell with those of you who are struggling with dystonia, the shaking and the involuntary posturing. I'll give you all a moment to memorize this diagram. I'm joking. This is from that same paper by this person, Broyle. I think it's actually Martha. I think he's in San Diego at UCSD in the anesthesiology department for pain management. This is sort of showing the concept of what's going on with this entity of complex regional pain syndrome, both the peripheral changes initially where people have some sort of trauma, they have inflammation, they have immune responses that are triggered by the peripheral trauma, which is then communicated to the central nervous system, both the spinal cord and the brain. I mean, this is what the brain is supposed to do if you have trauma. It increases the sensitivity to pain in that area so that you don't continue to injure it, to stop that whatever happened to cause the injury in the first place. But there are other things that are going on. So there are so-called markers of inflammation, things like substance P and bradykinin, and something called calcitonin gene-related peptide, or CGRP, that are found in peripheral circulation in the bloodstream. You can find these things that are markers of inflammation. And there are also antibody or immune responses that have been detected in people. And some interesting experiments were done in the past where antibodies from humans who had this entity, the CRPS, were injected into mice with just a minor kind of injury. But those antibodies seem to induce this syndrome, this complex regional pain syndrome in the mouse that received the antibodies. So there's also this concept of an immune response that is abnormally triggered, which then in turn causes further brain changes. Well, so is the question, what's all the value of this discussion? Well, maybe from this entity of complex regional pain syndrome, there are clues about what's going on in somebody with dystonia. I can't tell you how many times I've heard over the years somebody with cervical dystonia, for example, said, "Oh, I had a bit of a stiff neck initially, or I sort of hurt my neck," and but not any kind of traumatic injury, nothing, or dramatic injury, nothing that they thought was substantial, no head bump, no car accidents, no fall and hitting their head. Just some sort of, oh, I seem to have hurt my neck, and now I'm having this involuntary posturing. What we've been doing is, over the years, over the decades, certainly of my career, is looking at the end result of dystonia, the changes in the brain that are observed by imaging studies, as I mentioned, and then intervening in the end result with things like, well, Botox injections, which came on the scene in the mid-'80s, actually, and botulinum toxin, now Botox, and other types of toxins as well, which were a huge leap forward, actually. The treatments for dystonias prior to the arrival of toxin injections were oral medications, mostly anticholinergic medications, which were just an observation, mostly out of a group in New York City at Columbia University. Found that they seemed to work better, but those medications are just fraught with side effects: dry mouth, constipation, sometimes mental fogginess. And so when botulinum toxin came on the scene, first in the form of Botox, approved in 1989, December, I remember it well, not specifically for cervical dystonia at that time, but for blepharospasm, was one of the earliest indications. That was a huge step forward, but I think all of you who are dealing with dystonia know that it's not necessarily although it's been very helpful over these decades of use, I think it still leaves some things to be desired. So the question is, should we be thinking about using anti-inflammatory agents early? And maybe we should be paying more attention to how can we find people early on who have the beginnings of dystonia? Are there clues of things that may be occurring? As an aside, in Parkinson's disease, which is people with Parkinson's sometimes get dystonia, people with dystonia don't get Parkinson's disease. But in Parkinson's disease, there's been a lot of attention over the past, 15 years or so about early indicators. What could be signs that people could be later developing the motor manifestations of Parkinson's disease? And there have been clues: impaired sense of smell, something called REM sleep behavior disorder, altered bowel function. There's this idea about the brain and the gut connection in Parkinson's disease has been getting increasing attention over time. So maybe we should be trying to find dystonia before the usual years, 2 or more years that people go through, patients go through, trying to find out what is it that I've got? What's causing my head to shake and my head and my neck to hurt and my head to move? We know, all of you know, that that's not necessarily an easy and prompt diagnosis, that people go through clinician after clinician trying to find out what is going on here and get a misdiagnosis of cervical spine arthritis or essential tremor of the head until somebody finally recognizes it as cervical dystonia. I have to say, as an aside, I saw a woman recently in her 40s. It was heartbreaking, actually. She had been through the usual stuff of seeing different clinicians over a period of time. And her main complaint was her head tremor. But she didn't really have tremor elsewhere in her body. I don't remember that she had any hand tremor, for example. And when I asked her, she very clearly had a head tremor. That was obvious when I came into the examination room. But when I asked her to close her eyes and to relax, I don't know if you can see me or not, but her head clearly rotated to the right, to her right. She had very conspicuous cervical dystonia, but with her complaint of head tremor, she was getting a diagnosis of essential tremor of the head. And I don't think anybody had asked her previously to close her eyes and relax and then observe the rather marked and classic evidence of cervical dystonia. So should we be trying to find people early and perhaps use anti-inflammatory agents early? I mentioned this one marker of inflammation, calcitonin gene-related peptide. There are now, and have been for some time, a number of medications on the market, readily available for migraine that treat calcitonin, that block calcitonin gene-related peptide, CGRP, and thereby treat migraine. I don't know if you pay attention, they're in the popular culture. I'm sure you all recognize Khloe Kardashian, but she's one of the spokespeople for one of the products. Nurtec is a CGRP active medication. It's taken orally every other day now for prevention of migraine, but it's acting at CGRP. There are several other medications. Some of them are once a month injections. Others are by oral delivery as well to block this inflammation communicated by CGRP. You might have seen in some of the biographical information, I published a case report recently of a woman who had abdominal migraine, and she was treated. Well, she had also headaches for her migraine. She had symptoms of abdominal pain since she was in her teens. And her abdominal symptoms dissipated after her migraines were treated with Botox injections. And it's been reported, and I commented in my paper, that when people are successfully treated with Botox injections in their scalp, the systemic CGRP levels go down. So that you can modify this circulating inflammatory protein in a number of ways, not just by Botox injections, but also by oral medications. A coming thing, this picture looks kind of ridiculous, but this is actually an illustration of a device that's on the market now from a company called Cephaly, which is used to treat migraines by stimulating the nerves in the scalp. There are other devices as well. This is an ad from a wearable device. I don't know if you can see on the woman's right wrist, the elderly woman's right wrist. There's a device which is providing stimulation of nerves in her wrist, which are modifying signals to her brain to treat essential tremor, which is of great interest, not just to me, but also to my patients who have essential tremor. Instead of taking oral medications that don't work so well, or other methods, invasive methods, for example, deep brain stimulation surgery to treat their tremor, they can wear this device and have some partial relief of the tremor. And it occurs to me that something similar could be done to modify that picture, that loop, that peripheral communication with the brain loop that I showed you earlier on, that perhaps we could be, one, trying to find people early when they're starting to develop dystonia, use anti-inflammatory or immune modulating medications to prevent it or reduce the manifestations of dystonia. And once there, perhaps we could also be trying to modify this sensory motor loop by using peripheral devices that people would wear, maybe on their head, maybe on their wrist, for example, to try to stop that sensory motor integration problem or reduce it anyhow. This is an interesting paper. It's about 5 or 6 years ago now, 7 years ago now, by a group in Japan, small study using something called galvanic vestibular stimulation. So these people in Japan are putting electrodes on the mastoids, the bone right behind your ear, to stimulate the vestibular system in people with Parkinson's disease to alter their, what is really kind of a dystonic posture, this bending forward or leaning to one side. And they reported success in doing so. This is a different device, which is also vestibular for vestibular stimulation. It's not using electrical stimulation at that mastoid bone. It's instead, people put this device on like earphones, and you might see that little tip sticking out. It actually inserts into the ear canal. And the ear canal is then heated and cooled in a very gentle fashion to provide vestibular stimulation to, again, treat some symptoms, either in Parkinson's disease or conceivably dystonia. This device is undergoing trials, or should be getting off the board, getting off soon in terms of a human study of a larger scale. They've already published about 40 patients using this kind of device with benefit. And it occurs to me that this could potentially be applicable to dystonia as well. That's a picture of a glacier in Iceland. That is really the end of all the slides I put together on the topic. And that is me with my mask hanging off my ear. And if there are questions or comments, I'd be happy to hear them now. So Martha, if you want to open up questions and comments, I'd be happy to hear them.